quality of life in the clinical setting. Over to you, Sarah.
Thank you, and thank you for inviting me to speak on one of your webinars. So my name is Sarah Henshaw, as already been said. I'm the lead myeloma clinical nurse specialist at Nottingham University Hospitals. Been working as a myeloma nurse specialist since 2007, so I've been doing it for quite a while. This afternoon, I'm going to briefly talk to you about assessing and maintaining quality of life in the clinical setting. So we're going to talk a little bit about the incidence of myeloma and the impact that survivorship has on quality of life in myeloma. Then I'm going to go into a little bit about patient-reported outcome measures scores in the myeloma setting. And then I'm going to talk about the piece of research that I did for my dissertation, where I actually actively used a PROMS in that piece of research. So myeloma, as we know, has an incidence of approximately 60 to 70 cases per million inhabitants of the UK. And it's the third most common blood cancer, and it's the 19th most common cancer in the UK. It accounts for only 2% of all new cancer cases per year, so it is quite a rare type of cancer. As we know, myeloma is a relapsing and remitting cancer, but it is incurable, but it is very treatable these days. Life expectancy for patients living with myeloma is also increasing. So the 5-year net survival of people living with myeloma diagnosed between 2013 and 2017 was 52.3%. This is an increase from 22.2% between 1990 and 1991. 29% of patients diagnosed between 2013 and 2017 survived more than 10 years or more. So the myeloma 10-year survival in the UK has quadrupled in the last 40 years from just 6.4%. And this is down to all the new treatments that we have out there, meaning that people are living longer with myeloma. So people are living longer with myeloma, but what impact does that have on their quality of life? Obviously, with all the new treatments out there, there's now accumulation of complications such as peripheral neuropathy, pain, cataracts, fatigue, and endocrine disorders. And these do present challenges in the maintenance of quality of life for healthcare professionals. Living with long-term cancers has been shown to increase distress also, and the relapsing remitting nature of the disease and the high symptom burden can increase psychological distress, which impacts on quality of life, which is demonstrated in those two studies identified there. There was also a multi-center cross-sectional study that demonstrated that high symptom burden and that there's a link between that and mental health symptoms. 40% of patients experience symptoms of depression and anxiety that are living with myeloma, as well as the high symptom burden. And people living with myeloma may also experience long-term consequences of the disease and long-term effects of the multiple treatments that we now give for myeloma. And particularly since a lot of the treatments that we give dexamethasone and steroids alongside the treatments. So the long-term effects of steroids is quite a big thing within myeloma. The increase in survivorship and accumulation of late effects has created this new unique syndrome that we're now all working with and the patients are living with. And being able to maintain these symptoms, to maintain a decent quality of life, is becoming a challenge. So patient-reported outcome measures. There are lots of patient-reported outcome measures out there. And they are basically a way of patients being able to let us know how they're feeling at that point in time when they're completing the questionnaire. Within cancer care, patient-reported outcome measures generally are a really good way of undertaking holistic need assessments on patients, and particularly with people living with myeloma. In 2017, BSH developed and released some guidelines on late effects and long-term consequences. And this recommended the use of holistic needs assessments in 4 out of the 14 subheadings of the late effects and long-term consequences that they discussed. These being psychological well-being, pain, fatigue, and impact on workability. In 2014, Macmillan Cancer Support produced documents and developed holistic needs assessments, and there are electronic holistic needs assessments available through Macmillan for use for holistic needs. And as we know, PROMS is a really effective way of assessing holistic needs for a patient, and so that we're looking at every aspect of their life. Within myeloma, we're quite lucky. So there is a myeloma palliative outcome score that's also known as MyPOS, and this was the first myeloma-specific quality of life questionnaire that's been designed for use within the clinical setting. MyPOS has got a theoretical foundation. There's undergone a lot of qualitative studies, and it's undergone refinement with cognitive assessment. MyPOS is brief, it's comprehensive, it's acceptable to patients, as they did studies to see how patients felt that when they were filling it out. Was it quick and easy for them to complete? And it's been shown to be a valid, reliable, and it's responsive on psychometric testing. It's available free to download on that link there. If you go on the internet and just Google MyPOS myeloma, you will come up with that link. Once you go on there, you have to register for the first time. It's free to register. And once you're registered, you have access to the Word and the PDF versions of the questionnaire that you can edit yourself and put your own hospital headings on, etc. This is what the MyPOS questionnaire looks like. So I don't quite know how this looks on your screens because it's quite small, but it's 3 pages long. The first page, those first couple of questions are predominantly about the physical aspects of living with myeloma. And the last 2 questions about all the other aspects of living with myeloma. So the psychological, the social, work, sexual, everything that you can think of. And also when thinking about mortality, there is a question on there about whether you think about your future in there. So it can instigate and open up questions around that within clinic. At Nottingham, what we've started doing is trying to use the MyPOS questionnaire within clinic to try and help reduce down consultation times, because it means that patients have actually thought about their symptoms before they turn up for clinic. And the doctors in clinic use that first page to have a look and see whether they are getting any of those significant symptoms. By doing this, this focuses the appointments. As we know, myeloma is really complex, and patient appointments are getting longer because the disease is becoming more complex to manage. And this helps shorten down the appointment slots and make it more structured. It enables structured self-reporting of the side effects from the patients. So instead of the doctors or the nurses saying, have you had this symptom? Have you had that symptom? It gives them the opportunity to look at all the different symptoms and to be able to report that back themselves. If you use MyPOS in conjunction with a distress thermometer like we do, it can be an alternative to holistic needs assessment. So we do it in conjunction with a distress thermometer, because if you can imagine, if you had all of your patients in clinic completing a MyPOS questionnaire every time they come to clinic, it's difficult to screen them all to be able to actually see whether any patients are reporting any problems. So what we do is we have a quick look at the distress thermometer, and if they're scoring higher than a 7 out of 10 on their distress, that instigates us to then look at the MyPOS questionnaire and look further into what's causing that level of distress at that time. Is it a physical symptom? Is it something social? Is it something psychological? So how can you use it? Apart from in clinical practice, it can be used in research. So in clinical practice, it is really useful as a holistic needs assessment tool. In clinic with the doctors, it can be really useful for reducing down appointment times. And for the patients themselves, it helps them look at their myeloma and their illness in a more structured manner. And they can actually look appointment to appointment, if they are completing them every time, to see whether things are changing or things getting better. So it is really useful from that point of view. But actually, you can use the MyPOS questionnaire within research. And as you know, within many studies, we use patient-reported outcome measures within research for quality of life assessments. So there are the normal quality of life assessment tools that are used in many research studies. but MyPOS is specific to myeloma. So it's my belief that this needs to come into more of the clinical trials that are happening out there. The problem with the MyPOS questionnaire at the moment is it's not electronic, so it is very difficult and very arduous to actually get your data off of a MyPOS questionnaire for the purposes of research. But what I decided to look at as part of my MSc dissertation was improving the long-term quality of life of patients living within myeloma, and I did a bit of a service evaluation around that. So what I did was I did part of the evaluation was an audit. So I actually audited to see whether we were doing the late effects test that we were supposed to be doing in clinic. That was a simple yes or no. The other side of the question of the service evaluation was to look at what effect stage of the myeloma pathway had on symptom burden and levels of distress. Because if you don't know where symptom burden's getting heavier in the pathway, you don't quite know when to step in with the late effects monitoring, etc. So I did a quantitative formative service evaluation using the audit of the current screening, and then I used one-way MANOVA, which is a quantitative way of looking at how something has an effect on something else. Symptom burden in this was actually assessed using the MyPOS questionnaire, and distress was looked at using the distress thermometer. So symptom burden, what I did, looking at distress was quite easy. That was a simple, what score was the scoring on the distress thermometer when they completed their questionnaire. From the point of view of symptom burden, I just used question 2 on the MyPOS questionnaire, which is on the right there. So this is where patients complete individually whatever symptom it is, and they go from not at all up to overwhelming. And as you can see, very tiny at the side of those boxes, there is a number equated to those. So I was able to input that into a database to get an average and get a mean severity of symptoms. So I looked at questionnaires that were completed between May and November in 2019. During that time, there was 276 questionnaires and distress thermometers completed. I excluded 53 due to them being incomplete. So some didn't have the patient details on, some didn't have all of the questions completed, some didn't have the distress thermometer completed. So all those were excluded. I also excluded asymptomatic disease because I was looking at symptom burden for people on treatment, and that left me with 223 people. The mean age, as you would expect, was 73, with a range from 40 up to 94. So this shows that this questionnaire is quite easy to complete, and you can have older people completing the questionnaire as well as younger people. And it was almost 50-50 between male and females completing the questionnaire. Overall, those on active treatment that completed the questionnaire was 70%, with only 29% that weren't on active treatment. So this graphically shows that there were more patients that completed questionnaires on treatment than off treatment. And then the 2 bars to the right-hand side that's boxed in green, that shows the early stage versus late stage questionnaires that were completed. So there were more patients in the early stages of treatment that were completing the questionnaires than at the later stages of treatment. Early stage was classed as patients on first-line treatment through to when they were on monitoring after second line, and then later stage was classed as third line and beyond. So this gives a bit of a breakdown of the individual symptoms and what patients were scoring. And I think the significant thing here is that the severely and overwhelming, which is the yellow bars and the light blue bars to the right-hand side of each of the symptoms, are actually quite low. Where you would expect it to be on the higher side is in the areas that you would expect it to be. So with pain, and then because of pain, the poor mobility. And obviously you're tingling in your hands and feet because of the peripheral neuropathy that's associated with a lot of the treatments that we use. Nausea and vomiting were actually really low in the priority of problems for patients, which again you would expect with myeloma treatments, because there's not many of the treatments that actually cause nausea or vomiting. And then the other thing where patients were complaining quite a bit about is drowsiness, difficulty remembering things, which goes hand in hand with drowsiness, and weakness and lack of energy, which goes hand in hand with being on treatment sometimes. So when we looked at the distress, I say we, that when I looked at the distress across the pathway, the lowest levels of distress were reported in patients who were off treatment after first line treatment. So at the time when we was doing this, not many patients, if they were intensive, were on lenalidomide maintenance, for example. So when they'd completed their first line treatment, they were off treatment at this point, which shows that they have a lower level of distress. Patients on treatment in the fourth line setting had the highest levels of distress, which is something that you would expect, followed by those off treatment post third line, which again you would expect, because as patients are relapsing off of the third line, they know that they're going to fourth line and beyond, where you're starting to run out of your lines of therapy. And the other place where you would expect distress to be a little bit higher is obviously patients taking first line treatments. So this is when they're newly diagnosed. It's still a very emotional time for them. So you would be expecting those to be scoring a slightly higher level of distress. So when you look at distress in patients on treatment versus off treatment, so the box plot to the left is those that are on active treatment. And as you can see, the midline is higher than those that are off treatment, demonstrating that, as you would expect, patients that are on active treatments have a higher level of distress to those that are off treatment. So when we looked at the MANOVA analysis, so the MANOVA analysis overall is to find a link between two things. So you're kind of looking, does something have an effect on something else? That's what MANOVA does, but it does it in a numerical way. The effect of the stage of treatment has on symptom burden and distress can be looked at through this. So with MANOVA, you need two parts. You need your dependent variables and you need your independent variables. Your dependent variable is your mean severity of symptoms and the distress score. The independent variable is the one that doesn't change. So this is basically, they completed the questionnaire and they were on second line treatments, and that's not going to change. Whereas your dependent variable can be different for every individual. So the independent variables was the stage of treatment that they were at when they completed the questionnaire. And to make it easier for the analysis, you have to break it down into only two sections. So this is why I broke it down into the early stage of the pathway and the late stage of the pathway. So when you look at the descriptive statistics, the main thing on this is the distress score in those that were in the later stage of the pathway was higher, the mean, as well as the mean severity symptoms in the later stage was slightly higher as well, which correlates with the graph that we was looking at earlier about people who suffer the symptoms. When you're doing MANOVA, there's lots of different tests that you do to come out and show whether you've got an effect on something. So one of the tests that you do is the Wilks Lambda test, and this looked at overall position in the pathway and whether it had an effect on well-being. And this is when you are saying that well-being is measured by level of distress and the mean severity of symptoms. And actually the F was 13.35, which was significant. So it did show that position in the pathway did have an effect on the well-being of the patient. The other part that you do with it is you do tests between subjects. So this actually shows that position in the myeloma pathway has an effect on the patient's perceived level of symptoms. And then also it showed that the position in the pathway did not have a significant effect on the perceived level of distress. So I kind of took that as a thing that myeloma patients live in, no matter what stage of the pathway they're in, they're going to be suffering a level of distress. But it didn't show that it was significant at any particular point of the pathway. However, as you would expect, you mean severity of symptom, it did have an impact on stage of pathway, because it would all depend where the patients are at, what they'd already been through previously, what toxicities they'd got, whether they'd got extramedullary disease and bony progression, etc. The other bit that we look at is pairwise comparison. So patients' perceived level of symptoms when it's measured by the mean severity of symptoms, that it was significantly affected by the early or the late pathway. But again, the perceived level of distress was not affected by early or late stage of the pathway. So that's another way of looking at it within the MANOVA analysis. So overall, the highest proportion of patients were taking third-line treatments that completed the questionnaires. The symptoms perceived by patients demonstrated that the most frequently reported were pain, weakness or lack of energy, drowsiness, poor mobility, and tingling in the hands and feet, which are all common problems that patients living with myeloma have. And nausea and vomiting were found to be the least likely experienced symptoms by the patients. Distress was found to be higher overall when on treatment, but the highest level of distress was perceived in patients that were off treatment post third line, and in those patients on treatment in first or fourth line. Distress was rated as lowest after completion of first line treatment, and overall the whole pathway, the levels of distress reported was not above 7, where intervention was needed anyway, which is a positive thing. Position in the pathway did not affect the overall well-being of the patient, did have an effect on the whole well-being of the patients. But when you looked at the pairwise comparisons, the position in the pathway had an effect on the perceived level of symptoms, but it did not have a significant effect on the distress, suggesting that the level of symptoms does not correlate with distress. So what are some of the implications of quality of life of this? It shows that it's really important to be monitoring quality of life, because sometimes when you're having a conversation with a patient in clinic, you don't get all the answers of what you need and how severe this is impacting their life. And using some kind of PROMS alongside a distress thermometer can help you understand how patients are feeling and how it is impacting on their life. Management of late effects and long-term consequences and of the disease and its treatments should really be monitored through nurse-led clinics. It would be really nice to get some late effects clinics set up within the myeloma service. I know these are clinics that have been run quite regularly over the years in the bone marrow transplant service, for example, but these things aren't happening within myeloma. And I think if patients are living longer, we really do need to take these things into consideration. I know working in myeloma for a long time, we've always been aware that patients need, excuse me, cataract operation over the years, but these things can try and bring these out in the forefront. Another big thing from my dissertation was education of the myeloma team. So I haven't got around to doing this yet because I completed this during the pandemic, and as you can imagine, it's been quite busy since then. But I want to be able to present this to our doctors within clinics so they can see the importance of patients actually completing the MyPOS questionnaires, because at the moment, although we use them in clinic, it's very hit and miss to which patients complete them and which don't. I want to get it embedded in practice and make sure that it's happening regularly. So overall, the importance of the myeloma nurse specialist. I'm a nurse, I'm always going to big up the nursing role. Sorry, the dog's scratching and knocking my laptop. So people live with myeloma for multiple years, making it a chronic condition. Increasing survivorship is creating problems with late effects and long-term consequences of living with disease. And late effects and long-term consequences is increasing symptom burden, and therefore management is becoming more complex. And I think the main thing about patient-reported outcome measures is we need to use these to allow patients to communicate to us how they're feeling and how it's impacting on their life. The nurse specialist role is central in the support of this group of patients, and it's the nurse specialist that can instigate the patient-reported outcome measure or a holistic needs assessment, whichever it is that you want to do. We've personally moved over to MyPOS questionnaire in Nottingham, as we didn't feel that the Macmillan one gave us enough information that we needed to know off of the patient. And by doing this, we can help patients get through the treatments that they're on, because a lot of the treatments these days are continuous therapies. They don't get many breaks between treatments in this day and age compared to 10 years ago, where they would have a line of treatment, they would stop treatment and have reasonable quality of life whilst they waited for the myeloma to progress. And also managing the toxicities. So if they are reporting the physical symptoms more readily and more structured, then the side effect management will become better for the patients. And the better you manage the side effects, the longer the patients stay on treatment for. We know what it's like. If you've got a patient that's really struggling to take a treatment, if you can manage their expectations of being on treatment and actually manage how they're feeling and manage the side effects, it means that they will stay on treatment for longer. And staying on some of these long-term therapies for longer, because you're tolerating them, gives a better overall survival and progression-free survival between lines of therapy. And I always like the iceberg analogy, that as nurses generally, we're like icebergs. You can only really see 1/5 of what we're actually doing at a time. And this is really important when you're considering what we do as nurses. So yes, there's the physical aspect and the patient coming to clinic and getting their prescription and being organised for the treatment, but it's the other 4/5 of things that's going off in the background to try and maintain their quality of life. And I can't strengthen enough how important PROMS are from that aspect. So that was my short and sweet presentation about things. So thank you for listening. I think there's an opportunity to ask questions now, I do believe.
Yes, thank you, Sarah. That was a really interesting talk. So we've got a few minutes. We can open up the floor if anyone has any questions for Sarah. Well, I can start. How did you find the patient's acceptance of the MyPOS? Were they quite happy to complete the questionnaires?
Yes, I think because at the moment it's not electronic, they were more happy to complete it because it was a piece of paper and they were just going down and ticking boxes. I think our group of patients, particularly in sort of the Midlands and North, are more happy with paper questionnaires rather than the electronic questionnaires. So we actually found that they engaged with it better than they did the electronic holistic needs assessments that Macmillan do, because we found that really difficult to get them to do it. Mm. And they open up a little bit more. So I don't know if you can remember on one of the previous slides on the first page, if you can see it. On the first page, there's question 1, which opens up what are your main concerns at the moment. So if they've got a free hand to write whatever their problem is, we've seen some very interesting answers in that point, which kind of like, we can't solve your life and make you win the lottery kind of scenario. But it's usually sensible questions like, I'm struggling, I can't drive at the moment because my eyesight's going down, and it's that kind of thing. And then there's also the free space at the bottom where they can list any other symptoms that they're getting that's not mentioned in them core symptoms there. So it kind of covers everything. And I think the patients quite like that free bit where they can write some extra bits in. And if the doctor's using it properly in clinic, it can be really helpful for them, because it stops that whole, you've finished your consultation, the patient's getting up to walk out the room, and then they go, I forgot to mention this, and they come back and sit down again for another 10 minutes. So it does help from that perspective. But yeah, they are quite engaged with it.
Would I ask
would you like to ask a question?
I'd like to ask a question, but I don't know whether I'm on or not. It's Lisa. Can
Yes,
you
we can hear you?
I can hear you, Lisa.
Oh, smashing. Thank you, Sarah. I'm not familiar with the MyPOS questionnaire, but I have filled in a lot of similar sorts of questionnaires over the years. And when it gets to the part where it says, are you a carer or a patient? I always press patient, but I just wonder, has it ever been taken into consideration how many myeloma patients are actually carers themselves? I mean, I'm a full-time carer for my husband who has advanced Parkinson's. And when you talk about distress and psychological problems, obviously they're really, really a lot more than I would normally have to put up with what I've got. I just wondered if that was ever taken into account on any of these questionnaires.
Yeah, I mean, I don't know if you can see on the questionnaire towards the end, it does.
Can't read it.
No, I know, but there are questions on there that would open up if you were having a conversation with your nurse specialist about, are you, sorry, my dog's pushing the laptop again. It does open up those kind of conversations. So you would hope as a nurse specialist that you would know that you're a carer for your husband from when you first meet at diagnosis. But it does say, over the past week, have you been able to carry out your normal, usual activities without help from others? Over the past week, have you been able to pursue your hobbies and leisure activities? Over the past week, have you been able to spend quality time with your family and friends? And then there's a couple of other bits, but I can't see them, just glancing down quite quickly. But right. It does ask questions as well about whether you're worrying about your illness. And one thing that I've noticed with our patients is, if we've noticed that they're scoring a high level of distress on the distress thermometer, and we go on and do a holistic needs assessment telephone appointment with them, we go through all these questions, and we actually make sure that we're delving into, well, why is that the situation? And there's the one. Over the past week, have you been able to share how you are feeling with your family and friends? So if somebody ticked no, not at all in that, it would be, well, why? And, you know, the question, you know, the answer would probably come back, because I'm full-time carer for my husband and he suffers with dementia, or, you know.
Yeah, it's all right. Well, it's when the unexpected happens, like you're taken into hospital for a week and you don't expect it. And to be quite honest, I don't think I've ever had those many of those conversations with my nurse specialist, because I'm not entirely sure who my nurse specialist is, but that's another conversation. However, obviously it is on the form, but it would be nice to somebody to sit down and do that with me, I think. Thank you anyway.
Yeah.
Thank you, Lisa. Does anybody else have any other questions for Sarah? Well, I've got one extra one. How often do you think it would be for patients to do the MyPOS questionnaire? And also, do you think that this should be more regular in later pathways if we're seeing that it's linked to that patients are suffering more distress?
I personally think that in an ideal world, looking through rose-tinted glasses, if money, time, all the rest of it was thrown out the window, I personally think these should be completed every time somebody comes to clinic, or even when they're having treatment, you know, because like that lady's just said, actually, if you're not completing these things and looking at them properly, it's not going to open the conversation up, and you're not going to find out that she's carer for somebody and she's struggling from that aspect. And all of a sudden, then when they get into a line of therapy where you need to be an inpatient for your loading doses, you know, and that tends to be the later lines of therapy, then, you know, it shouldn't be then that you're finding out, well, actually, no, I can't come in as an inpatient because I look after my husband that's got dementia and I've got nobody to look after him. You should know that beforehand. And I think if these are done actually more regularly, now I know time is a restraint because we struggle, you know. I can't say that we categorically do this at every clinic visit, because it doesn't happen for every patient at every clinic visit, because we have problems of getting the questionnaires out and the doctors remembering to hand them out in clinic and the patients handing them back in, etc. So it doesn't happen, but it should. What was the second question?
I think it was, should it be more regularly if it was later down the pathway?
Yeah,
suffering with stress.
I think in an ideal world, if you can't do it all the time, all the way through the pathway, then you should really be concentrating on it from sort of third line onwards, because this is where some of the more problems crop up. And as my research showed, you know, symptom burden is higher in the later lines of therapy. Distress not necessarily is, but that's because distress is running the same over the whole pathway. So yeah, I would definitely say third line and beyond, you need to be making an effort to do these holistic needs assessments or MyPOS questionnaire, whichever it is that you need to do.
That's great, thank you. Well, we've been building MyPOS into our clinical trials that we've been running through CARP, and they've been accepted by patients, and we've been getting some results back, so that's really good to see. And it's really nice to be hearing more about your research and how we can be using it and how it links in with the patient in a clinical setting. Does anybody else have any final questions? Or if not, we shall let Sarah go and we will bring the webinar to a finish.